Capacity is one of those things that everyone talks about, but a lot of people don't quite understand. So I'm going to give you a crash course on how to assess for capacity in the hospital from a psych resident. First and foremost, when you're looking at a patient's ability to make decisions, you need to think about what paradigm we're working with. Capacity is often conflated with competence, but it's much different. Competency is your global ability to make consistent and effective decisions about your care. Is this person competent enough to care for themselves? But capacity applies to a single decision at a single point in time. When you're asking about competency, think global decision making and think lawyer and judge. My tweed jacket at the bedside isn't going to be able to decide if this person in their whole lifetime can make decisions to care for themselves, or if they need a guardian or a medical power of attorney. That's going to be decided in a courtroom. But in the hospital, we can decide if they have capacity to make a single decision. So now that we're looking at capacity, we go down this tree to decide, okay, yes or no, do they have capacity? It kind of works like a ladder where they have to each clear decisions, and if they fail at one of these steps, we pull off and say, okay, this person does not have capacity. Branching point starts out pretty easy, which is, are they awake? If someone comes in a car crash and they're unconscious, they don't have capacity to refuse surgery. And I think a lot of people can understand that one, but there are times where people are somnolent or they just had a seizure or other things and they're not able to interact or have any kind of coherence. That's not capacity. The other one that can run in line with that is delirium. So if a patient is confused and they have waxing and waning levels of consciousness, they can't sustain their attention long enough to have a conversation with you, they also do not have capacity. Sometimes people might be scared because this 90-year-old delirious patient is saying a lot of wild things, but ultimately their level of consciousness or the level of cognition is not consistent with someone that can make a rational decision about their care. Okay, so let's say you've established the patient is awake and alert, they're lucid, they know what's happening. What's next? Can they voice a decision? So in that scenario, the patient may be lucid, alert, and oriented to their surroundings, but they don't understand the 30,000-foot view care plan that's actually happening, and they don't see the decision tree. Okay, is there a surgery that I can refuse or have to agree to coming up? They just know doctors are doing things to me. Surgery. There are times where people will be like, does this person have the capacity to refuse surgery? And then my follow-up question is, do they even know they're having surgery? That's not a case where you'd say, oh, you don't understand there's a decision, therefore you don't have capacity. We're going to go back and say, okay, actually, let's give you some information, say, hey, you need surgery for X, Y, and Z. A classic example of this might be someone who has peripheral vascular disease and they have osteomyelitis in their foot. They need to have surgery to get the foot amputated, otherwise they might become septic and die. So let's say they're refusing surgery to get this amputation. They voice the decision, but they also need to voice it consistently. This is another important part. If they're changing their mind literally every 10 minutes, or they consent to the surgery, and then the second they try to go to surgery, they say they don't want it anymore, and then they come back, and then they say they do want the surgery, and then they don't want it, that's not a sign of consistent, cogent thought. So let's say they're saying no, they consistently voice this decision. Now we need to look at the treatment. So can they understand the pros and cons of receiving the treatment? And if we say, hey, why are we giving you this surgery? And they say, I don't know, because you just want to. Well, that's a sign that they don't understand why they want the surgery, but we're not going to just jump and say you don't have capacity right away. This is why we need to bring the primary team with us all the time to have these conversations, because the surgeon or whoever's performing the surgery is the one that should be explaining to the patient why they need that surgery. It is super annoying when I get consulted on a patient and the primary team doesn't want to come see them with us, and then they're asking me, like, why do I even need this surgery anyways? And I'm like, I don't know, I'm the psychiatrist. And as a psychiatrist, I don't know the difference between surgical and medical interventions on septic foot or osteomyelitis. I've seen people that got antibiotics for their osteomyelitis. I've also seen people get amputated, but I don't treat this every day. I don't know the differences. I can't tell you why this is the way that's recommended. The surgeon's the one who decided anyways. I didn't decide this. Not to get mad, but if a patient is refusing a care decision that you're making, please be there to stand by that decision, and don't outsource it to a psychiatrist to come by and explain it to the patient and force them to go through that reasoning. It's not fair to the patient. It's not really fair to the psychiatrist. Having the surgeon there to explain it to them and then see if the person can internalize or incorporate the new information into their decision making. So we explain to them, well, the pros of the surgery are it would eliminate the infection and preserve your chances of survival. The cons are you lose your foot and there's risk of bleeding, damage to other structures, and things like that that are standard for procedures. So can you appreciate the pros and cons of that? If they can voice that information back to you, then you need to look at this other branching point, which is, can they understand the pros and cons of refusing the treatment? This is where I start to get more open-ended with the questions for the patients. I say, hey, if you refuse this treatment, what do you think is going to happen realistically? And this is actually where a lot of times we end up finding that patients don't have capacity, because then they'll say, well, I'll just go home and keep living my life. And we're like, well, we just explained to you that if this foot doesn't get amputated, you're going to become septic and die. This is a scenario where they're like, no, I won't. And you're like, help me understand why you know that you won't. And this is usually where there's difficulty in like proposing reasoning or appreciating that there's like any amount of risk that will happen if they leave the hospital. This isn't to say that someone can't refuse this surgery with the knowledge that there is a risk of them dying, but they need to articulate to us that they can understand and appreciate that there is an elevated risk were they to refuse this surgery. So if I'm like, do you appreciate that there's a risk of refusing the surgery? They're like, yeah, I could be hit by a car. Everyone has a risk of dying. I'm like, that's true. I have a risk of dying leaving the hospital, but do you appreciate that you have a much elevated risk of leaving the hospital with a septic foot? And then if they can't, then that's tough. They fall off the train, they don't have capacity, especially after multiple iterations of trying to explain this to the patient. Maybe they say, yeah, I understand there's a huge risk I might die, but because of my religion, it's important for me to have all my limbs intact. I don't think life would be worth living without a foot. That's why I want to refuse the treatment or pursue with alternative treatments that may be less effective. And I've been skipping a little bit here, but we see that the patient can understand the pros and cons, but now we need to really clarify, do they appreciate the risks, and is that appreciation influenced by mental illness in any way? The most important example of this is if someone can understand that there is a risk of death, we need to interrogate why are they okay with dying. It's much different to say, I'm okay with dying because I've made my peace. It is my religious constructs prohibits me from living without a foot. It's internally consistent with a belief system that you followed for a long period of time. But what if the patient says, I'm okay with dying, and I ask why, and they're like, because life sucks, I was gonna kill myself anyways, and this might as well just speed up the process. So now this enters kind of a new question. Is this patient depressed and they're suicidal and they're refusing surgery because they're hoping that they will die? Depression is a modifiable factor. So if this person were not depressed, maybe they would not want to die and they would not want to refuse the surgery. So that's something we have to intervene on or try to treat in the meantime. The other thing we come across is psychosis. Psychosis can definitely affect how someone appreciates the benefit of a surgery. Maybe they understand the surgery will cure their septic foot, but they think a huge risk of the surgery means that we're going to implant a tracking device in them and then use it to follow them around and siphon out cryptocurrency from their bank account to ours, which we can use to propagate the New World Order of vampire lizards. A really important point is that psychotic patients do not automatically not have capacity. Their psychosis has to directly be related to the decision that they're making. I can have paranoid delusions that the FBI follow me around, and I can still have an internally consistent belief system that I shouldn't live without a foot. Those two things are unrelated, and my psychosis is not directly impairing my ability to comment on this decision. So some people think a patient has schizophrenia or schizoaffective disorder, therefore they don't have capacity. That's not necessarily true. The important thing is that we see that someone has a rational, consistent appreciation of the pros and cons of both the treatment and the treatment that they're refusing. And capacity can change. People can become incapacitated and then gain capacity later. Sometimes you have to readdress these questions, especially if things like psychosis and depression are modified. I know we always say any doctor can assess for capacity, and that's true, but I get called on it all the time. I think I've stopped caring enough to fight back. So all I say is if you do call us for capacity, at least have asked the patient if there's like a question that they're deciding on, and then please come see them with us. I don't want to have to explain to a patient why they do or do not need neurosurgery because I'm not a neurosurgeon. Okay, that's the end of my soapbox, but hopefully this helps with capacity. Thanks.